invasiveness in adenocarcinoma, presenting as pure ground glass opacities, the Gordon study by Dr. Catalini Gureni.
Good morning. I would like to thank the committee for giving me the opportunity to present our work today. I have no disclosure to declare. Pure ground glass opacities are increasingly identified on a CT scan, especially in case of lung cancer screening. They are often associated with early-stage lung cancer, and they are typically indolent. They have predominant lipidic growth pattern and a favorable prognosis, especially in case of minimally invasive adenocarcinomas and adenocarcinomas in situ. However, the surgical treatment consists in anatomical resection with systematic hilar and mediastinal lymphadenectomy that could come with prolonged operative time, possible post-operative complications, and prolonged hospitalization. There are several works that show that in case of pure ground glass opacities, there is a small risk of lymph node involvement. So we ask ourselves, is systematic lymphadenectomy always necessary in case of radiological pure GGOs? And is it possible to identify which pure ground glass are truly invasive based on CT findings? And can we use this to guide our surgical decision, especially whether to omit lymphadenectomy? From here started the idea of the Gordon study. This is a retrospective multi-center study that included 6 Italian high-volume thoracic surgery centers, Rome, Milan, Padova, Siena, and Naples, and we included all patients that between 2013 and 2024 underwent surgical resection and lymphadenectomy for adenocarcinomas presenting as pure ground glass opacities. We decided to exclude PGGOs bigger than 4 centimeters, patients with previous solid lung tumor, and patients underwent inadequate lymphadenectomy or inadequate preoperative and follow-up radiological evaluation. Here you can see all the variables that we investigated. Of course, qualitative CES CT analysis, quantitative CES CT analysis, histological diagnosis, and of course the follow-up at 1, 3, and 5 years. The first goal was to evaluate the incidence of lymph node involvement in surgically resect pure ground glass opacity. Our secondary goal was to assess the lymph node recurrence and to identify eventually radiological predictors of histological invasiveness. For what regards the radiological predictors, we investigated qualitative parameters such as the margins, the bubble-like lucency, the pleural attack, and of course the bronchus sign, the vascular supply, and of course quantitative analysis such as the maximum diameter of the lesion and also the density of the lesion. We evaluated in an enhanced and anterior phases with a long window, placing the region of interest, the ROI, on the most representative part of the GGOs, avoiding vessel as bronchi. The same ROI was then copied onto the arterial phase to ensure consistency. Of course, we have done the same thing for the parenchyma to calculate these 2 variables, the difference CT value and the relative attenuation, that are the difference and the ratio in density between the nodule and the surrounding healthy parenchyma. From 474 patients, we included 400 patients that were divided into invasive adenocarcinomas and non-invasive adenocarcinomas, including minimally invasive adenocarcinomas and adenocarcinomas in situ. Here we can see the first results. As you can see, the majority of the patients underwent lobectomy, maybe an overtreatment in this case of indolent lesions. And you can see that the prevalent growth pattern was acinar in case of invasive adenocarcinomas and lipidic in case of non-invasive adenocarcinomas. But here you can see the most striking results. The 100% of patients didn't show any lymph node involvement, and that the lymph node disease-free survival at 1, 3, and 5 years was 100%. Here you can see the CT findings. Here you can see that the qualitative analysis, the speculating margins, the pleural attack, and the bronchus signs were predictive factors of invasiveness. And a higher maximum diameter, a higher density in an enhanced CT scan and post-contrast CT scan, and also the different CT value and the relative attenuation were predictive factors of invasiveness. Here you have 4 variables that you can evaluate only just with an enhanced CT scan. So we decide to take these 4 variables and to do single rock analysis to individuate the threshold above all we can predict the invasiveness. Here you can see the values, but we were not very satisfied with the sensitivity and specificity of this result. So we decided to do a combined rock curve with these 4 variables. As you can see, the maximum diameter and the GGO and enhanced CT attenuation were confirmed independent predictors of invasiveness with a specificity of 82%, a sensitivity of 76%, and an area under the curve of 87%. The different CT value and the relative attenuation were complementary rather than independent predictors of invasiveness. Which are the key findings of this work? Of course, as you can see, despite their indolent imaging appearance, a large majority of pure GGOs were invasive, the 86%. Despite this, no lymph node involvement was identified, suggesting their extremely low nodal metastatic potential. And we saw also an excellent long-term disease-free survival, the 100% at 5 years. Radiological predictors such as the radiological diameter higher than 18 millimeters, a basal CT attenuation higher than minus 390 Hounsfield units, pleural tab, bronchial sign, higher arterial phase CT attenuation are predictors of the invasiveness. And these CT-based measures are simple and reproducible. So, which are the clinical implications of these findings? Of course, we can guide a precision resection strategy for this kind of pure GGOs. And also, we can guide our follow-up and surveillance. We can decide when to resect the nodules during their follow-up, their CT follow-up. And of course, we can manage the multiple GGOs. As you can see, we can find different GGO in the same patient, but they are very different. So we can decide which to resect before. In conclusion, pure GGOs, even when invasive, carry minimal risk of lymph node involvement or recurrence. These findings support a paradigm shift toward de-escalation of lymphadenectomy in carefully selected patients with pure ground glass opacity. Our findings highlight the clinical value of simple or rapid CT measurement, particularly the lesion size and attenuation, which provide a strong predictive value for histological invasiveness and may guide a more individualized conservative surgical approach. And finally, in the context of lung cancer screening, the integration of radiological predictors, such as the lesion size and attenuation into clinical workflow, may allow for more personalized surgical strategies. Thank you very much.
We'd like to invite Dr. Kelvin Lau from the Bars Thorax Center to